Welcome back to the deep dive. Today I'm sweating a little bit. We are putting aside the casual curiosity and we are entering the war room. If you're listening to this, you're probably staring down the barrel of the MD anesthesiology exams or, maybe the EDAI or the FRCA. You've got the book stacked up, Miller, Harrison, the ICU book, and you're realizing that you have a massive blind spot.
And that blind spot is usually located in the retroperitoneum.
Exactly. The kidneys. Everyone loves the heart. We can, draw the cardiac cycle on a napkin. Everyone understands the lungs. But the kidney feels like the black box where we dump fluids and drugs, cross our fingers, and just hope urine comes out the other end.
That is a terrifyingly accurate description of how many residents approach the kidney, and it's exactly why examiners destroy candidates on this topic. It's the silent killer in the Viva.
So here is the mission for today. You are going to take on the role of the senior faculty, the scary one with the glasses who holds the marking sheet. I am the postgraduate student who has read the books but is struggling to connect the dots. We are going to convert those thousands of pages of text into a survival guide for renal function tests and anesthetic drugs in renal dysfunction.
I accept the role. And I'll tell you right now, this isn't just about memorizing normal values. The kidney is where physiology meets dangerous pharmacology. If you don't respect the kidney, your patient doesn't wake up. Or they wake up seizing.
Great. No pressure then. So let's look at the roadmap. We need to start with the why. Why does the examiner care so much? Then we need to do a serious deep dive into renal function tests, the RFTs, because I have a feeling I'm interpreting them wrong. Then we hit the pathology, AKI versus CKD, and finally, the real meat of this deep dive, the drugs.
And not just listing drugs. We need to talk about mechanisms. Why can you use fentanyl but not morphine? Why is succinylcholine basically a loaded gun in these patients? We'll wrap up with a structured plan for that big 20-mark long question.
All right, part A, the introduction. Let's start there. Why is the kidney the examiner's favorite weapon?
Okay, think about the three-legged stool of perioperative risk. When you assess a patient for any major surgery, say a pneumonectomy or an aneurysm repair, what are the three pillars you're balancing on?
Of the heart, obviously. Lungs, and I'm guessing the third leg of this stool is the kidney.
It is, but people treat it like a distant third. They really shouldn't. The kidneys receive 20 to 25% of your total cardiac output.
25%? That's insane.
It is an insane amount of blood flow for two organs that weigh about, 150 grams each.
So that's a quarter of every single heartbeat just going straight to the kidneys.
Correct. Which makes the kidney the canary in the coal mine. If your patient is hypotensive or if cardiac output is dropping, the kidney is often the first organ to sense it and suffer. It shuts down to preserve flow to the brain and heart. So if you see renal dysfunction, you aren't just looking at a plumbing problem. You are looking at a patient with absolutely zero hemodynamic reserve.
So in the exam, if I get a case that says chronic renal failure for surgery, the examiner isn't just checking if I know how to dialyze.
No, not at all. They are checking if you realize that this patient likely has accelerated atherosclerosis, severe hypertension, probably some stiff ventricles, anemia. The works. Miller is very, very clear on this. Renal dysfunction is a major independent predictor of postoperative mortality and cardiac events.
Right.
If the kidney is sick, the heart is almost certainly sick too.
Okay, that definitely raises the stakes. So how does this actually show up in the exam papers? What am I walking into?
You'll see three main patterns. First, the long question, 20 marks. It'll be phrased something like, describe the biomarkers of acute kidney injury and discuss the anesthetic implications in a patient with chronic renal failure undergoing renal transplant.
Wow, that's a beast. That's a 4-page answer right there.
At least. Second, you've got the short notes. These are like sniper shots. Rifle Lee versus KDI Go criteria, or Compound A. Creatinine clearance. You either know these cold or you don't. There's no waffling.
And the third one?
The Viva trap. This is where I, as the examiner, I lean forward, I take off my glasses, and I ask you, Doctor, you said the patient's creatinine is 1.0. Why is serum creatinine a terrible marker for early renal failure?
Ugh, I hate that question, because 1.0 looks so normal.
And that is why we fail you on it. So let's move to Part B, renal function tests. We need to dismantle this myth of the all-powerful serum creatinine.
Let's do it. We rely on this number every single day. Why is it so terrible?
It's terrible because of a concept called renal reserve. Think of the kidney like an airplane with 4 engines. The kidney is incredibly redundant. You can lose one engine, lose 25% of your nephrons, and the plane flies just fine. You lose 2 engines, 50% function, and the plane still flies fine. The alarms don't even go off.
And the speedometer? the serum creatinine, it doesn't change.
Barely. This is what we call the creatinine blind spot. You have to lose approximately 50% of your glomerular filtration rate, your GFR, 50% of your functioning kidney tissue, before the serum creatinine even begins to rise above the upper limit of normal.
Wait, let me just process that for a second. I could have a patient who has lost half their kidney function, who is effectively operating on one kidney, and their lab report will come back saying creatinine 1.1 mmHg normal.
Precisely. The relationship between serum creatinine and GFR is not linear. It is exponential. It's a curve. In the early stages of the disease, a massive drop in GFR causes a tiny, barely noticeable rise in creatinine. It's only when you are in severe failure that the creatinine finally shoots up.
So if I see a patient whose creatinine has gone from, say, 0.8 last year to 1.1 today,
to the untrained eye, both are normal. They're in the green zone on the lab report. To the astute anesthesiologist, that patient has just lost a huge chunk of their renal reserve. You must look at the trend. Spot values are dangerous. A single number tells you almost nothing.
Okay, but where does this stuff even come from? Why is it so variable between people?
That's the next trap, the muscle mass trap. Creatinine is a breakdown product of creatine phosphate, which is in skeletal muscle. So the amount of creatinine you produce depends entirely on how much muscle you have.
I've heard the bodybuilder versus grandma analogy before.
It's a classic because it's absolutely true, and it trips people up every day. Imagine a 25-year-old bodybuilder. He's 100 kilos of solid muscle. He is churning out creatinine constantly. His baseline normal might be 1.3 mmHg. If he comes in with a 1.3, he's perfectly healthy.
Okay, now take the 85-year-old lady from the nursing home. She weighs 40 kilograms, she's sarcopenic, she has almost no muscle.
Exactly. She produces almost no creatinine. Her baseline might be 0.4. Now imagine she comes into the ER with a perforated bowel and her creatinine reads 1.0.
The lab computer won't even flag that. 1.0 is well within the normal range.
Exactly. But for her, she has more than doubled her baseline. She's in acute kidney injury. She has lost maybe 75% of her kidney function. And if you dose her drugs, assuming she has normal kidneys because the number is 1.0, you might kill her. You are dealing with severe renal failure that is completely masked by muscle wasting.
That is genuinely terrifying. It really emphasizes that we have to look at the patient, not just the chart. Is there any issue with how the kidney itself handles creatinine? Does it play fair?
No, it cheats. This is another key point for the Viva.
Right.
Creatinine is mostly filtered at the glomerulus, which is what we want for a GFR marker, but about 10 to 20% of it is actively secreted by the tubules directly into the urine.
So the urine contains more creatinine than was actually filtered through the glomerulus.
Yes, which means that creatinine clearance overestimates the true GFR. And here's the real kicker. As the kidney starts to fail, as GFR drops, the tubules panic and start secreting more creatinine to try and compensate, to get rid of it. So the worse the kidney gets, the more the test lies to you.
Okay, so serum creatinine is officially on my do not trust list. What about its partner in crime, BUN, blood urea nitrogen?
BUN is even worse. We call it a dirty marker.
Dirty.
Because it is influenced by so many things that have absolutely nothing to do with the kidney. In the exam, I will ask you, doctor, list 5 non-renal causes of an elevated BUN.
Okay, let me try. BUN comes from protein breakdown, so a high-protein diet, a big steak dinner.
Correct. That's one. What else?
A GI bleed.
Yes. Why?
Because
Yeah.
the blood is protein, and it's being digested in the gut.
Exactly. You are digesting your own blood cells. That is a massive protein load that gets absorbed by the gut. Upper GI bleed is a classic cause of a high BUN. What else?
Dehydration.
Yes, that's a big one. And steroids. Corticosteroids are catabolic. They break down protein. So if a patient is on high-dose prednisone for, say, an asthma exacerbation, their BUN will be high even if their kidneys are perfect.
But we do use BUN for something useful, right? The ratio, the BUN to creatinine ratio.
The urea-creatinine ratio, yes. This is its one saving grace. It helps us distinguish pre-renal from intrinsic renal causes of failure.
Okay, walk me through the logic there.
It's all about reabsorption. Urea is reabsorbed by the kidney tubules. Creatinine is not much anyway. When the patient is dehydrated, when they're in a pre-renal state, the kidney thinks, I need to save water.
Sure.
To save water, it aggressively reabsorbs sodium, and urea follows along for the ride. So the urea in the blood shoots up disproportionately high compared to the creatinine.
So a high ratio like greater than 20.1 means the kidney is just thirsty.
Correct. The kidney itself is functioning. It's just holding on to everything it can to preserve volume. But if the kidney tissue is damaged, like in intrinsic renal failure, The tubules are dead. They can't reabsorb anything, so the urea just leaks out into the urine. In that case, both urea and creatinine rise together in the blood, and the ratio stays low, like less than 15.1.
Got it. High ratio equals dry, low ratio equals damaged.
Yeah.
Okay, now let's talk about the math, the eGFR. The labs give us this number automatically now, which is nice.
They do. They use formulas like the MDRD or, more commonly now, the CKD EPI equation. It's important for your exam to note that these formulas are evolving. Historically, they included a race correction factor. They assumed that Black patients had a higher muscle mass.
But that's been really controversial, hasn't it?
It has, and rightly so. The 2021 guidelines have moved to remove the race variable to prevent systemic bias in diagnosing and staging kidney disease. Mentioning this shift in your written paper shows the examiner that you're reading current literature, not just the 10-year-old textbook.
So is there a better blood test out there? Something that doesn't depend on muscle?
There is. It's called cystatin C. It's produced by all nucleated cells in the body at a constant rate. So it's not affected by muscle mass, age, or sex in the same way. It's a much better marker for early changes in GFR.
But we don't use it routinely.
No, because it's expensive and not available in every lab, but it's the new kid on the block and definitely something to mention as a more accurate, albeit less accessible, test.
Okay, what about the physiological gold standard? What's the absolute best way to measure GFR?
The true gold standard is inulin clearance. Inulin is a plant starch. It is freely filtered by the glomerulus, and it is not reabsorbed or secreted by the tubules at all. It is perfect.
But we never use it.
Because you have to infuse it intravenously at a constant rate and collect timed urine samples via a catheter. It's a pure research tool. The clinical gold standard is creatinine clearance, which we usually estimate using the Cockcroft-Gault equation.
I knew this was coming. We have to memorize this formula, don't we?
You have absolutely no choice. It will come up. Recite it for me.
Okay. It's 140 minus age, multiplied by weight in kilograms, and you divide that whole thing by 72 multiplied by the serum creatinine.
Good. And if the patient is female?
You multiply the whole final result by 0.85.
And why do you do that?
Because, on average, females have less muscle mass than males for the same body weight.
Correct. Again, it all comes back to muscle. Now, why do we bother calculating this? Why not just look at the eGFR the lab computer spits out?
For drug dosing.
Bingo. Most drug package inserts, especially for antibiotics like vancomycin and, crucially for us, some muscle relaxants base their original dosing guidelines on studies that use the Cockcroft-Gault equation. If you use the eGFR from the lab, which is often normalized to a standard body surface area to dose a drug, you might be off. For precise drug dosing, always calculate the clearance.
Okay, that's a really important clinical point. Before we leave RFTs, let's talk about the urine itself. In the OR, I stare at that urometer like it's a crystal ball.
We all do. The textbook definition of oliguria is less than 0.5 mmHg/hour, but here is a huge warning. Oliguria does not always mean failure.
This is the surgical stress response, right?
Yes. Surgery is trauma. Trauma releases ADH or vasopressin and aldosterone. The body is programmed to hold on to salt and water during an injury. A patient can have oliguria with perfectly normal, healthy kidneys that are just doing their job.
So just chasing that low urine output with liters and liters of fluid might be the wrong thing to do.
It often is, but you can't just ignore it either. You have to investigate. You have to look at the FENA, the fractional excretion of sodium.
This is that pre-renal versus renal test again, but with urine.
Exactly. If the kidney sees low blood flow, if it's in a pre-renal state, it holds onto sodium like gold. It wants to expand the body's volume. So the amount of sodium in the urine is tiny. The FeNA will be less than 1%.
And if the kidney itself is damaged?
If the tubules are dead, which is what happens in acute tubular necrosis or ATN, they can't reabsorb sodium. The sodium just spills into the urine. In that case, the FeNA will be high, greater than 1% or 2%.
But there's a trap here, isn't there? The Lasix trap.
Oh, the classic resident mistake. You see low urine output, you panic. You give 20 milligrams of furosemide, or Lasix. The urine output might increase a little bit. Then you decide to send the urine for electrolytes to check the FeNA.
And the FeNA comes back high.
Of course it does. You just gave a drug whose entire mechanism is to block sodium reabsorption. That's what loop diuretics do. You have artificially created a high FeNA. You can no longer use it to diagnose pre-renal failure.
So if I've given Lasix, the FeNA is completely useless.
Yeah.
Is there an alternative?
Yes, and this is a great point for the exam. You can calculate the fractional excretion of urea, phe-urea. Diuretics don't really affect urea handling in the same way, so if you've given diuretics, look at the phe-urea. If it's less than 35%, it's still likely pre-renal.
That is a solid clinical pearl. What about looking at the urine under the microscope? The books are always talking about casts. I just nod along, but what is a cast?
This is pathology 101, but it's important. A cast is simply protein or cellular debris that has congealed inside the renal tubule, taking on its cylindrical shape. When it finally flushes out, it looks like a microscopic little cylinder or worm.
And the famous muddy brown casts.
That is the tombstone of the tubular cell. It is dead, sleuthed-off epithelial cells mixed with heme pigments. If you see muddy brown casts on the urine sediment exam, the diagnosis is acute tubular necrosis, ATN. It's not pre-renal anymore. The damage is done.
Okay, so we've gathered our data from the blood and urine. Now we need to put it all together. Part C, interpretation of abnormal RFT.
We divide acute renal failure into 3 big buckets: pre-renal, intrinsic renal, and post-renal. Pre-renal is a problem with the plumbing to the kidney, things like hypovolemia, hypotension, severe heart failure. Not enough blood is getting there. Post-renal is a problem with the plumbing after the kidney, an obstruction.
And you always have to rule out the blocked Foley catheter first, right?
Always. First step, flush the catheter. It is incredibly embarrassing to call the entire nephrology team for an urgent consult when the only problem is a kinked tube that's been trapped under the patient's leg for 3 hours.
And then there's the alphabet soup of saging, rifle kin, KD Go. This confuses everyone. Feels like they change the name every 5 years just to mess with us during our exams.
It's not to mess with you. It's an evolution of precision. Rifle was the first big attempt to standardize the definition. It stood for risk, injury, failure, loss, and end stage. It used both GFR changes and urine output criteria. Then AKIN, the Acute Kidney Injury Network, came along and said, hey, even small rises in creatinine matter a lot. So they dropped the GFR criteria and focused on an absolute creatinine rise of just 0.3 mmHg within 48 hours. And KDIGO is the current global standard. It basically synthesized the best parts of both Rifle and AKIN.
So if I'm answering the exam question about staging AKI, I should quote KDIGO.
Yes. You must quote KDIGO. And you need to know the basic stages. Stage 1, a creatinine rise of 1.5 to 1.9 times their baseline, or R, that absolute rise of 0.3 mmHg. Stage 2, creatinine doubles, so 2 to 2.9 times baseline. Stage 3, creatinine triples, so 3 times baseline, or the patient requires dialysis.
That's actually quite straightforward when you break it down like that. Okay, another common clinical problem, differentiating acute from chronic. The patient arrives in the ER, unconscious, no history. The creatinine is 5.0. Is this new or old?
This is a very common consult. You have to look for clues. 1, ultrasound. This is probably the most important test. Chronic disease causes scarring and fibrosis. Scarring shrinks tissue. So if the kidneys are small and bright on ultrasound echogenic, it's chronic kidney disease, CKD. If they're big and swollen, it's more likely an acute kidney injury, AKI. 2, anemia. Erythropoietin is made in the kidney. It takes a long time to become anemic from kidney failure. So severe anemia of no other cause suggests a chronic process. 3, bone disease. You can check a parathyroid hormone level. If it's through the roof, that points towards renal osteodystrophy, which again takes months or years to develop.
Okay, let's pivot now to our domain, the operating room. We are about to induce anesthesia on a patient with borderline renal function. The books talk about the triple whammy.
The kidney is terrified of the OR. It's a hostile environment. Whammy number 1, anesthesia. We give propofol, we turn on the gas, we do a spinal. What do all of these things do? They cause vasodilate. That leads to hypotension. Renal perfusion pressure drops. Whammy number 2, surgery. The surgeon makes an incision. The body screams. Catecholamine surge. The renin-angiotensin system fires up. The renal vessels clamp down vasoconstriction. And whammy number 3, the direct insults. We clamp the aorta, we put them on cardiopulmonary bypass, we inject IV contrast dye, we give nephrotoxic antibiotics.
It's a miracle anyone wakes up with working kidneys, really.
Yeah.
Is there a magic bullet to prevent AKI? I still hear people in the ICU talking about renal dose dopamine.
Stop! Let's bury this right now. Once and for all, renal dose dopamine is a myth. It does not work.
Wait, I was in the ICU just last week, and the senior consultant started a dopamine infusion at 2 or 3 mics per kilogram per minute. He said it stimulates the DA1 receptors in the renal arteries and causes vasodilation. That's the physiology, isn't it?
That is the physiology, yes. And it's true, it does increase renal blood flow and it makes the patient produce more urine. But the outcome data, and this is the only thing that matters, shows it does not prevent renal failure, it does not reduce the need for dialysis, and it does not improve survival.
So it just makes more urine, but it doesn't actually save the kidney.
Exactly. It's cosmetic polyuria. It's polyuria without protection. Plus, dopamine causes tachycardia and arrhythmias. You are stressing the heart just to produce a bit more urine. The international guidelines are explicit. Do not use low-dose dopamine for renal protection.
So if I suggest it in the Viva.
I will ask you for the evidence, and you won't have any. You'll look foolish. Stick to what works. MAP, mean arterial pressure. Keep the perfusion pressure up. Keep the patient euvolemic. Avoid nephrotoxins. That's it. It's boring, but it works.
Okay, so maintain perfusion pressure. Now let's get to the section I'm most nervous about. Pharmacology, Part D. The effect of renal dysfunction on anesthetic drugs.
This is it. This is where you pass or fail the Viva. You need to understand how renal failure completely changes drug handling. And it's not just about excretion. It starts with distribution and protein binding.
Okay, let's start with distribution. These patients are often fluid overloaded.
Right.
They might not have peed in days.
So their volume of distribution, the VED, for water-soluble drugs, is increased. They are a much bigger tank to fill.
So for a drug like a muscle relaxant, which is water-soluble, I might actually need a larger initial loading dose to achieve the same effect at the neuromuscular junction.
Correct. That's completely counterintuitive to most trainees. You might need a bigger dose to get them started, but because they can't clear it, you need tiny, infrequent maintenance doses.
And what about protein binding?
This is huge, especially for acidic drugs like thiopentone, if you still use it. Uremia makes the blood acidic. Acidosis changes the three-dimensional shape of the albumin molecule. The acidic drug can't bind properly to this altered albumin.
So if it can't bind to albumin, it just floats free in the plasma.
Yes. And only the free, unbound drug is pharmacologically active. Only the free drug can cross the blood-brain barrier. So in a uremic patient, a normal dose of thiopentone results in a massive overdose of active drug reaching the brain. On top of that, the blood-brain barrier itself is leaky in uremia, so drugs cross it more easily.
So the bottom line is, reduce all your induction doses significantly. Got it. Now let's go drug class by drug class. Inhalational agents.
Volatile agents are great for us in this situation because the lungs do almost all of the work of elimination. But we have to talk about sevoflurane.
Compound A.
Yes. In the presence of the soda lime and the CO2 absorbent, sevoflurane can degrade into a vinyl ether called compound A. And in rats, high concentrations of this stuff destroys their kidneys.
But are we rats?
We are not.
Yeah.
And there is no solid evidence in large human trials that compound A causes clinically significant nephrotoxicity. However, the FDA and the package insert still recommend keeping your fresh gas flows greater than 1 or 2 liters per minute, especially for long cases.
Just to wash out the compound and prevent it from accumulating in the circuit.
Exactly. If you run very low flow, like a closed circuit anesthetic, for a long time, compound A can concentrate. So, for the exam, your answer is, sevoflurane is generally considered safe, but I would maintain fresh gas flows of at least 2 L-min to minimize any potential for compound A accumulation.
What about desflurane?
Very stable molecule, very little metabolism, no nephrotoxicity concerns. It's an excellent choice.
And methoxyflurane. Just for the history question.
That is the classic history lesson. It caused a devastating high-output renal failure. It was metabolized to inorganic fluoride ions, which made the kidneys collecting ducts insensitive to ADH. The patient would pee 10 liters a day and dehydrate to death. We don't use it anymore, but it's a fake exam trivia question to see if you know your history.
Okay, now for the big ones. Intravenous induction agents. We covered thiopentone. What about our workhorse, propofol?
Propofol is mostly safe. It's metabolized by the liver to inactive glucuronides. The pharmacokinetics aren't drastically changed by renal failure itself. However, the clinical sensitivity is much higher.
So I should still reduce the dose?
Yes, but you're reducing it more because the patient is uremic, acidotic, and hemodynamically fragile, not because the kidney can't handle the drug itself.
Ketamine.
2 big issues with ketamine. 1, it has an active metabolite, norketamine, which is renally excreted. It can accumulate and cause prolonged sedation or delirium. 2, and more importantly for me, ketamine is a sympathome mimetic. It raises blood pressure and heart rate. If your renal patient already has uncontrolled hypertension, which they often do, spiking their BP even further is very risky.
And etomidate.
Great for hemodynamic stability, which is a plus. But you always have to remember the adrenal suppression. In a septic patient or someone who is already profoundly stress compromised, that might be a significant downside.
Let's move to opioids. This is the danger zone. I've seen this go wrong on the wards.
This is where the most common and most dangerous mistakes happen. Let's look at morphine. Morphine is metabolized in the liver. So people think, great, liver metabolism, the kidney is safe. That is dead wrong.
Because of the metabolites.
Yes. The liver turns morphine into M3G, morphine 3 glucuronide, and M6G, morphine 6-glucuronide. These metabolites are water-soluble. They rely 100% on the kidney to leave the body.
And M6G is the active one.
M6G is a more potent analgesic and a much more potent respiratory depressant than morphine itself. It accumulates and causes the patient to go into a coma. M3G is neuroexcitatory. It causes agitation, myoclonus, and full-blown seizures.
So a renal failure patient on a morphine PCA could be comatose and twitching at the same time.
Yes. It is an absolute nightmare to manage. You have a comatose, seizing patient. The answer is simple. Avoid morphine in severe renal failure.
What about meperidine or pethidine?
Even worse, its metabolite, normeperidine, has a very long half-life and is a potent convulsant. It causes seizures. It is absolutely contraindicated. There is no reason to use it.
So what are we supposed to use for pain?
Fentanyl is a good option. It has no active metabolites. Its effect is terminated mainly by redistribution into fat and muscle, so for single shots it's fine. But if you run a long infusion, the context-sensitive half-life will prolong significantly as those tissues get saturated.
But the undisputed king of renal anesthesia is remifentanil.
Absolutely. The gold standard.
Why is it so perfect for this situation?
Because of how it breaks down, it undergoes ester hydrolysis. It is literally eaten up by non-specific esterases in the blood and peripheral tissues. The kidney is completely irrelevant to its metabolism. The liver is irrelevant. You can turn off the infusion, and the drug is gone in 5 minutes, whether the patient has 100% GFR or 0% GFR.
That sounds perfect, but it's expensive and not available everywhere if I don't have Remy.
Then you use fentanyl carefully, small titrated boluses, or you look at other options like hydromorphone, which also has metabolites, but they're less problematic than morphines. But you still have to be very careful.
Okay, muscle relaxants. This is the other really big one. Let's start with succinylcholine.
The single word you must associate with sucks in renal failure is hyperkalemia. Succinylcholine creates a generalized depolarization of the muscle membrane. As a result, potassium rushes out of the muscle cells. In a normal person, the serum K+ rises by about 0.5 to 1.0 mmHg.
Which is fine if my potassium is 4.0. I go up to maybe 5.0. No big deal.
But the chronic renal failure patient is often starting at a baseline of 5.5. You push them to 6.5, you're going to see peaked T waves and risk arrhythmias. You push them to 7.0. You risk sine wave and cardiac arrest.
Is there a hard cutoff number we should use?
It's not absolute, but generally, if the pre-induction potassium is greater than 5.5 mmHg, you should not use succinylcholine. Also, be aware that some of these patients have uremic neuropathy, nerve damage from the chronic kidney failure, which can cause an upregulation of extrajunctional acetylcholine receptors, leading to an even bigger, more exaggerated potassium release.
So sucks is risky. What about the non-depolarizers?
Your drugs of choice here are atracurium and its isomer, cisatracurium.
Because of Hoffman elimination.
Exactly. They break down spontaneously in the plasma based on body temperature and pH. They also undergo some ester hydrolysis. They do not need the kidney or the liver. They are organ independent. But for the exam, you must remember laudanacine.
That's the breakdown product.
Yes. Laudanacine is a metabolite of both, and it is renally excreted. In very high concentrations in animal models, it can lower the seizure threshold. In practice, in humans, you would need massive, prolonged infusions to see any clinical effect. But it's worth mentioning to show the examiner you know the complete picture.
What about rocuronium? We use it for everything now. It's the standard for RSI in many places.
Rocuronium is mostly excreted by the liver into the bile, but about 10 to 20% is cleared by the kidney. So in severe renal failure, the duration of action is definitely prolonged. You can use it, especially for a rapid sequence induction if SUX is contraindicated, but you have to expect the block to last much longer than you're used to.
And what about reversing it with succomedex? This seemed like the magic bullet that made rocuronium safe for everyone.
It did, but there's a major catch in renal failure. Succomedex works by encapsulating the rocuronium molecule. It forms a tight, irreversible bond, like a molecular bear hug.
And then that whole bear hug complex has to be peed out.
Precisely. The succomedex rocuronium complex is a large, water-soluble molecule that is 100% renally excreted. If the kidneys don't work, that complex just stays in the blood for days.
Does it matter? If it's encapsulated, it's inactive, isn't it?
Theoretically, yes. But over time, there is a concern that the complex could become unstable. Rocuronium might dissociate and cause recuriorization or reparalysis hours or even days later. Plus, we just don't know the long-term toxicity of having that complex circulating in the blood. The current advice is avoid succomedex in severe renal failure, which is usually defined as a creatinine clearance less than 30 mmHg.
That is a crucial nuance. I would have just given it without a second thought. Okay, a quick but important one. NSAIDs.
No, just no. An absolute contraindication in anyone with renal compromise.
Give me the mechanism again. Why are they so bad?
It's all about the balance of power at the afferent arteriole, the vessel that brings blood into the glomerulus. In a stressed kidney from hypotension, from sepsis, the body is releasing vasoconstrictors like noradrenaline and angiotensin II to keep the blood pressure up. The kidney protects its own blood flow by releasing local vasodilators, specifically prostaglandins.
So the prostaglandins are the good guys here, keeping the door open for blood flow.
Exactly. They keep the afferent arteriole dilated. NSAIDs, like ketorolac or diclofenac, work by blocking prostaglandin synthesis.
So you take away the vasodilator, and the powerful vasoconstrictors win.
Exactly. The afferent arteriole clamps shut, GFR plummets to 0. You can cause immediate, severe, acute kidney injury. It's like stepping on the oxygen hose of a deep-sea diver. Never, ever use NSAIDs in a patient with a compromised kidney.
What about benzodiazepines, like midazolam for sedation?
Be very careful. Midazolam has an active metabolite, alpha-hydroxymidazolam. It accumulates in renal failure. If you use it for sedation in the ICU, your patient might not wake up for 2 or 3 days. Use it very sparingly, if at all. Propofol is a much better choice.
Okay, that covers the drugs. Let's move to the practical plan. Part E, anesthetic management, starting with the preoperative assessment.
First thing you look at is the dialysis schedule. Ideally, the patient should be dialyzed 24 hours before surgery.
Why not right before they come to the OR? Wouldn't that be better?
No. If they just came from a dialysis session, they are often hypovolemic or dry, and they are systemically heparinized from the dialysis circuit, so there's a bleeding risk. If they haven't been dialyzed in 3 days, they are fluid overloaded, hypertensive, and hyperkalemic. That 24-hour mark is the Goldilocks zone. They're euvolemic, and their electrolytes are reasonably balanced.
You mentioned the weight rule.
Yes. Compare their current weight to their established dry weight, which is their weight immediately after a dialysis session. If they are 5 kilograms heavier than their dry weight, that is 5 liters of extra fluid you have to deal with, probably sitting in their lungs and venous system.
And the K rule?
You must have a recent potassium level. Check it immediately pre-op. If it's greater than 5.5, you have to treat it, or, for elective cases, postpone the surgery.
Okay, intraoperative management. Let's talk fluids.
This is a huge debate. Normal saline versus balanced salt solutions like Ringer's lactate or Plasma-Lyte.
For years, we were terrified of the potassium in Ringer's lactate.
We were. But Ringer's only has 4 millieql of potassium. That's physiological. The bigger problem, it turns out, is normal saline.
0.9% ACO.
It has a massive amount of chloride, 154 NaAQL. It causes a hyperchloremic metabolic acidosis.
And acidosis shifts potassium
out of the cells and into the blood. So giving large volumes of saline can actually worsen hyperkalemia more than giving a balanced solution that contains a tiny physiological amount of potassium. The current trend definitely favors balanced salt solutions, unless the patient has a brain injury where the osmolarity of saline might be beneficial.
And, of course, the fistula.
That is the patient's lifeline. The mantra is, save the veins. You do not put IVs, BP cups, or arterial lines on the arm with the AV fistula. Before you do anything, you feel for the thrill, you listen for the bruit with your stethoscope, and you document that it is working before you put them to sleep.
Okay, post-operative pain. We've established no NSAIDs, no morphine, no Miradyne.
So you're left with a few options. Titrated doses of fentanyl, perhaps hydromorphone used very carefully, and ideally regional anesthesia. Peripheral nerve blocks are excellent in this population because they provide great pain relief while avoiding systemic drug effects and their metabolites. But remember, uremic patients can have platelet dysfunction, so be very careful with deep blocks or neuraxial techniques.
All right, this has been a huge amount of information. Let's bring it all together for the exam. Part F, exam integration. How do we synthesize this for the examiner?
You should have mental comparison tables ready to go. For drugs, it's safe versus unsafe. Safe. Propofol, anticurium, cisatricurium, fentanyl, remifentanil, desflurane. Unsafe for use with extreme caution. Morphine, meperidine, vecuronium, pancuronium, NSAIDs, cyclinocholine if K+ is high, Sugammadex.
Yeah, the common Viva traps. Give me a scenario.
Okay. I ask you, doctor, you have a patient with a perforated bowel who needs an emergency laparotomy. His pre-op potassium is 6.5. What do? Do not just say cancel the case. It's an emergency.
Okay, so I would say this is a medical emergency requiring surgical intervention. I will first institute immediate medical management of the hyperkalemia. I'll give intravenous calcium gluconate to stabilize the cardiac membrane, then insulin with glucose to shift potassium into the cells, and perhaps sodium bicarbonate. Then I will proceed with a rapid sequence induction, but I will avoid cyclocholine and use a high dose of rucuronium instead.
Excellent. That's a pass. You identified the problem, treated it, and tailored your anesthetic plan.
And what about the dopamine trap?
A firm, evidence-based no. Your answer is no, sir. While low-dose dopamine can increase urine output, multiple large studies have shown it does not improve survival or prevent the need for dialysis.
Okay, how should I structure that big 20-mark written answer?
Headers are your friend. Make it easy for the examiner to give you marks. 1. Introduction in physiology. Define RFTs. Talk about GFR, renal blood flow. 2. Pathophysiology. Define AKI using KDI-GO. Differentiate from CKD. 3. Pharmacology. Discuss the altered pharmacokinetics and pharmacodynamics, then go through each drug class with specific safe versus unsafe examples and mechanisms. 4. Clinical anesthetic management. Break it down into pre-op, intra-op, and post-op considerations. If you structure it logically like that, you can't go wrong.
Perfect. Let's try to summarize the absolute key takeaways. 1. Creatinine is a late and unreliable marker. You lose 50% of function before it even rises. 2. You must know the KDI-GO staging for AKI. 3. The single most important intervention is to preserve mean arterial pressure to preserve kidney perfusion. 4. Atracurium and remifentanil are your best friends in renal failure. 5. Absolutely avoid NSAIDs and be terrified of the potassium load from succinylcholine.
Now, my final thought, the sentence you can use to conclude your answer for the examiner. Remind them that the kidney is not just a passive filter, it is a complex endocrine and metabolic organ. It regulates blood pressure, red blood cell production, and calcium balance. When it fails, the whole body fails. Our anesthetic drug choices and fluid management must respect that central physiological role.
That is a fantastic way to close. This deep dive has made me feel much more confident about tackling the renal case.
Just remember the core principles, critical thinking over rote memorization. Understand the why and the what becomes easy.
For everyone listening, check the show notes. We'll put the CKD criteria table and a quick drug safety chart in there for you. Good luck with the exam. You've got this.
Good luck.
See you next time on The Deep Dive.